Mrs. Winnie advises there's something that we need to take up? What's that?
Yes, Judge. I want to take up a couple matters with you before testimony today. So the first issue I wanted to bring to the court's attention is
You found your audio? Good. Okay.
So the first issue I want to bring to the court's attention is, my understanding is Dr. Veal, the state intends on calling him to testify today. There are a number of objections that I'm going to raise prior to Dr. Veal actually testifying based on his report in our interview. The first thing is, in Dr. Veal's report, he has a number of statistical analysis. Well, it's not really an analysis because he just says that he pulls it from literature. He doesn't know how it applies to this this particular case. He's not an epidemiologist. He hasn't conducted any actual statistical analysis on this that would be appropriate. So that would be my first objection. I'd also raise an issue with regard to...
What kind of statistics are we talking about?
So he says in his report... Let me pull up, Judge. This is Exhibit 506. Talks about the role of methamphetamine. He says that the death rate associated with use of methamphetamine alone is very low, between 0.2 and 0.3 per 100,000 persons. When we asked him about how he got to that number, he just said that he had pulled it from literature. He's not sure how he got that data, or how the authors got that data, or how it would apply in this scenario, given the related cardiac issues or the strenuous activity. I mean, all the aspects of this particular case. The other thing he says is that the risk of sudden death for a ventricle wall thickness is about 2.4, well, he says 2.4 per 1,000 patients yearly. Again, same issue with foundation of that. Absolutely speculative. So those are some of the statistical points that I wanted to bring to this court's attention. I think the court remembers we brought that issue with Dr. Freeman. And the court granted that motion in limine. I'm not sure if the state still intends on calling Dr. Freeman for those purposes, but the other issue I wanted to raise, I don't know if the court just wants to take that up, but I had a couple other points with regard to the deal.
Go ahead.
Okay, so the other issue I wanted to raise with regard to Dr. Veal, and actually with regard to the other experts as well, is a confrontation issue, right? So these experts are relying upon the statements of other witnesses, including witness officers. And so in relaying that information, obviously, we have a right to confront those witnesses. I'm growing a bit concerned about the state's intention of whether they actually intend on calling those witness officers in this case. We're already way behind schedule. I was looking at the numbers last night, and if the state still intends on calling all of their experts, as well as the witness officers, as well as these other witnesses that they've noted, we're going to go into January until I think we're going to be able to put on a case, and that's going to be highly problematic. So I'm going to raise a confrontation issue with that regard, and I'm going to already start laying objections to any of that hearsay testimony. To the extent that we open the door to some of it, then I think it's fair game. But until that point, I'm going to raise an objection to that. So the other thing I wanted to bring to the court's attention regarding Dr. Veal is he says in his report he relies on the prior transcript regarding the "I can't breathe" statements. He relied on that Hallamore transcript, and the court's familiar with that, so I'm going to raise objections to him relaying information that the court's excluded from those transcripts. And the last thing I wanted to raise was with regard to the speculative nature of his testimony. And I think this goes actually for each one of the state's experts. They are placing blame on our client, Officer Rankine, but each one of, and they say that the weight of an officer on his back contributed to his death. But each one of them admit that they don't know how much weight or for how long. And so, they're really, I think there has to be an appropriate foundation for the facts that they're relying upon, right? They can't just speculate and say, well, I think it's the weight, but I don't know how long, and I don't know how much weight. And so I think that the speculative nature of that, I was looking at cases last night, and I can cite to the court a couple cases that I found. So this is it's called In Re Detention of Jaeger. It's Jaeger. It's an unpublished case, but it cites to.
What's the citation?
So sorry, it's number 72392-81. It's a 2016 case. So for persuasive authority.
Wait a minute, this is.
It's September 6th, 72392-8-1. And it's
Is that the number in the Supreme Court?
yeah, I mean that's the citation I got, but I can probably a better citation is to the State v. Kunze case, which is Kunze. That's 97 Wash App 832, and it's a specific cite to 850 note 67. And it says that when an expert desires to apply specific knowledge to the facts of a particular case, his or her opinion must also, of course, rest on appropriate case-related facts. The citation to Jaeger that I provided cites it to the extent that there must be sufficient factual foundation for expert testimony for the testimony to be relevant. So again, Judge, just looping back around to the timing of trial, I don't know if the state intends on calling Brandon, I'm blanking on his last name, I think it's McCallahan or something, McClanahan, today. He's a witness much like Cedric Armstrong yesterday, who really had very limited contact with Mr. Ellis, I think earlier that evening. Again, I have... My issue with the timing of trial, again, is I'm getting contacted by witnesses that I told them, I expect your testimony, beginning to mid of November. And I need to be able to tell them when we're actually going to have the state's case done and rested. And so that's, again, another issue I'm going to raise with regard to this as well. Thank you, Judge, for hearing me out. Appreciate it.
Mr. Liu?
Governor, it's hard to respond to cases that are being cited right now. Of course, the state hasn't had a chance to review those cases. But as far as the speculative nature of the testimony regarding the amount of weight and the length of time an officer was on top of Mr. Ellis, I think our experts, and especially Dr. Beal, would say that he relied on the evidence on the record. We know when fire got there. We know from Rankine's statement that he was on Mr. Ellis until fire arrived. Based on all that information that's available to Dr. Beal, he'll be able to testify. It's not speculative. It's based on the evidence. As far as the I can't breathe, I mean, Dr. Beal is relying on experts can rely on materials that, these are the type of materials that he relies on. He's entitled to rely on the transcript.
What exactly is he going to say here about this stuff? Give me an offer of proof as to his testimony.
Well, he will say that his testimony is going to be regard to the respiratory system and the impact that being in prone position has on the person's ability to inhale and exhale. And he will testify that having someone's weight on top of Mr. Ellis prevented his exchange of oxygen and carbon dioxide. And he knows from the testimony, or actually the statement of Mr. Officer Rankine, that Officer Rankine arrived at a certain time, that when he arrived, Officer Burbank was on top of straddling Mr. Ellis, and that Mr. Rankine stayed on top of Mr. Ellis except for that brief time in the recovery position until shortly as fire arrived. So we have that length of time that he's relying on.
Yeah, and then what's his conclusion from all that?
His conclusion is that the pressure on Mr. Ellis caused hypoxia, which led to PA and resulted in cardiac arrest.
And how much time does he say that Officer Rankine was on Mr. Ellis?
Well, I believe he will indicate that he would estimate about 10 minutes from the time that he arrived, Mr. Ellis, or Mr. Rankine arrived at the scene, assisted in holding Mr. Ellis down, getting on top of Mr. Ellis, to shortly, as far as arriving, that time elapses about approximately 10 minutes.
5 to 10 minutes.
Approximately 10 minutes.
And so does he have a conclusion then,
Yes,
that Officer Rankine caused the death of Mr. Ellis?
he will say the cause of death was, for Mr. Ellis' hypoxia.
We've already had that testimony.
But his testimony is based on the pulmonary science, based on the medical, from the pulmonary analysis, that Mr. Ellis was not able to exchange oxygen and carbon dioxide based on the pressure applied. This is not anything that our other experts have testified to. In fact, Dr. Wogerlichner, as defense pointed out during the cross, is not a pulmonologist. It's not really certified in pulmonology. Dr. Beal is.
But it doesn't sound like he's going to say anything different with respect to at least the mechanism of hypoxia because of constriction and the ability to expand and contract one's chest, right? We got that from Dr. Mitchell, too.
I don't believe so, Your Honor. I believe Dr. Veal, who is an expert in pulmonology, will talk about and explain to the jury how difficult it is to contract the ribs, to inhale and exhale. And this is nothing that we've presented so far in this case, Your Honor.
Well, that's why I'm asking for this offer of proof. I'm not hearing anything new.
Well, that is new. We haven't received, the jury have not heard from a pulmonologist to talk about the constriction of the ribs, preventing the diaphragm from moving, and the body being able to exhale oxygen and carbon dioxide.
Well, Dr. Mitchell said that his conclusion was mechanic hypoxia due to violence. This has more of an effect than hypoxia alone. He could not move his chest to breathe the way he needed to breathe due to people on top of him. Acidosis played a part due to lack of oxygen and in a struggle due to violent subdual of restraint, etc. Right? Didn't he say all
It's a
that?
very broad general description, but Dr. Veal, as a pulmonologist, would be able to provide the jury more detail on how that works.
But how can he say anything about what happened in particular in this case?
Because he examined the medical records, he examined police reports, he examined the officer's accounts of what occurred and how Mr. Rankine was positioned on top of Mr. Ellis. And he's able to tell the jury that based on the positioning, that it prohibited Mr. Ellis from his ribs from expanding. He'll explain the bucket handle, pump handle movement of the ribs that prevented Mr. Ellis from being able to exchange oxygen and carbon dioxide.
At another point, he says, I'm talking about Dr. Mitchell. That his placement on his stomach with his arms and his legs behind him made it hard to expand the chest to breathe off the acidosis. Also, the placing of a person on Ellis's back would make it hard to breathe. All this is causing his death. Hypoxia causes acidosis. Decrease of oxygen to heart causes heart to slow down and it begins to try to have the body use less oxygen and produces acid. The combination of those things led to Ellis's death. Hypoxia is not fatal if treated early enough. We solve this by breathing heavily or by the provision of oxygen by medical providers, typically. If not available, it'll be fatal. There's evidence that Ellis was placed in a prone stomach position with people on his back in a restrained position. This impairs his ability to sustain life. The fight increases need for oxygen and increases his metabolism. Being restrained hampers his ability to get oxygen, to catch his breath. What's different?
Well, that's from a pathological expert's perspective. Dr. Veal will talk about his oxygen reserves and the lung's ability to bring in more oxygen when compressed, which he was unable to do. And he'll also be able to talk about why it is, especially in response to Officer Rankine's statement, well, if you can breathe, if you can talk, you can breathe, he'll explain why that's simply not the case, that you do have oxygen reserves, but you can expel it as you're talking, but you're not able to bring in more oxygen. Those are details that a pulmonologist will be able to testify to explain to the jury. And that's not something that's all has been presented to the jury before.
What about the business about the statistics about sudden death from ventricular wall thickness? That sounds like a cardiologist, not a pulmonologist.
Well, he is an expert witness, and he relies on statistics to come to his conclusions and opinions, and these are the type of data that experts rely upon regularly.
Yeah, but the question in any case like this is not what are the odds that this would have happened before it happened. The issue is what happened here, and certainly some people die from this, and certainly some people die from methamphetamine overdoses. So what difference does it make that the incidence of it happening today for any particular person is 1 in 150,000 or whatever it might be?
And that's fine, Your Honor. The state could avoid going there, but Dr. Veal's testimony is important. It is unique and significant. It comes from a pulmonologist's point of view regarding the cause of death.
Sounds like we're talking about the same thing over and over again.
And I would offer to the court that we're not. This is a pulmonologist.
Yeah, you've said that, but how is that different from what I've already received?
Because he is going to actually talk about the mechanics of the ribs and the sternum and the ability and the effect of having weight on top of someone, press it against the ground, the ability of that person to be able to exchange oxygen and carbon dioxide. And that's, again,
But I've read to you my notes from what the other doctor said.
I'm sorry, Your Honor.
I said, I've read to you from my notes of what the other doctor said about that, and I'm not hearing anything different from what Dr. Mitchell said. And you've also got Dr. Clark yet to come, right?
Yeah, Dr. Clark is a pathologist, and Dr. Mitchell is a pathologist. Dr. Veal is someone who treats like patients and deals with people who have pulmonary issues, and so, that's different.
So also Dr. Smock is also going to be apparently talking about these very same things. From a pulmonology.
Dr. who?
Smock. He's the police surgeon general.
Is that the guy from Louisville or whatever?
Correct. And then 2 use of force experts.
Right?
I mean,
Go ahead, Mr. Liu.
What Dr. Veal would also instruct the jury is how the respiratory system works. And you will have illustratives, and you will explain how the respiratory system works, how the rib cage expands and contracts with guarded breathing, and how the movement of the thoracic wall occurs during breathing, and how that's restricted. And this is something that a pulmonologist should be able to testify to that no other experts in this case will.
Except for the one who already has that I'm aware of. Well, what I'm trying to figure out is how is he trying to tie this into any particular action of a defendant here? Or is he even going to offer that?
Yes, Your Honor, he will indicate that having an officer on Mr. Ellis's back prevented Mr. Ellis's chest wall from expanding and being able to take in enough oxygen, which led to hypoxia, which led to PDA and cardiac arrest.
Well, that's what Dr. Wohlgenertner said.
Dr. Wergerner's testimony came from a cardiologist's perspective, and he didn't go into the details of pulmonology, which, again, the defense pointed out during cross. You're not a pulmonologist, are you? You're not board certified pulmonologist, are you?
Well, yeah, he did also say about that he has a good understanding of pulmonary medicine. While it's not his focus of study, pulmonary issues are sometimes heart-related. He had rotated into emergency room work from 2005 to 2019, where he also saw methamphetamine-afflicted patients about once a month.
But again, he is not a pulmonologist.
Yeah, but I know, but it goes on to say, his notes, according to my notes, every cell needs oxygen. Oxygen provides fuel for chemical reactions in the cells. Some parts of the body, like the brain, need more oxygen than others. The heart is no different. Deprived of oxygen, it will be a problem. The muscle of the heart is more sensitive than the electrical system of the heart, so the electrical system can still be working for a time after the muscle of the heart is compromised by lack of oxygen. It malfunctions without oxygen. Cardiac arrest can occur. He described what hypoxia is. Hypoxia is common from lots of sort of possibilities.
And what is clear from that, Your Honor, is he's testifying from a cardiologist's point of view and from a heart point of view. Dr.
Sure.
Wheeler
Then
is
he,
testifying regarding the respiratory system.
well, let me add, restrained asphyxia. A respiratory system is not capable of functioning normally by compression of the chest wall to expand and contract to bring in sufficient oxygen, led to inadequate oxygen and then cardiac arrest. This was due to Ellis being prone on a hard surface with weight applied to his chest while also being This was due to Ellis being prone on a hard surface with weight applied to his chest while also being restrained. Cardiac arrest here was due to hypoxia first occurring. I looked at the LifePak data. This was not a primary heart event, but the hypoxia. Ellis said he could not breathe. Police ascribed a difference in the pattern of his breathing, parentheses for me, agonal breathing, close paren, sequence of loss of breathing, apnea and loss of pulse, EKG patterns are consistent with this. Bradycardia, first occurring is typical with asphyxia rather than heart attack occurring. Isn't that all the same thing?
It isn't, Your Honor.
Explain to me just a little bit. The mechanics isn't going to cut it because he's explained the mechanics, and so did the other one.
Having Dr. Beal will testify about the rib cage being constricted, not being allowed to expand, and he'll explain to the jury the bucket handle concept and the pump handle concept of how the thoracic, the rib cage must be able to move up and down in order to breathe and exchange oxygen. And he'll talk about the lung disorders and how it's slowly running out of air because you just cannot intake enough oxygen, which led to hypoxia. This is, again, a pulmonary explanation of what occurred here that the jury has not received.
Didn't you guys tell me on the first day of trial that Dr. Neal was not going to testify?
No.
You guys remember that? I've got a note in my notes that say that.
No, we did not.
William Neal expert, question mark. No one will,
William Neal is a defense expert.
no one's going to call him.
Correct.
Okay, so that's my mistake. So how do I spell your expert's name?
V-E-A-L.
V-E-A-L. Veal, instead of Neal. Okay, so on our motions on, I guess this was in July. '20th. The question was, Dr. Curtis Veal, the defense asked if Dr. Mitchell's testifying, why is Dr. Veal needed? And I think I reserved a ruling on it until I heard some offer of proof about what he was going to say and heard what else had to happen here. And I'm not hearing anything that's different than what's already been testified to. And there was overlap, obviously, between Dr. Mitchell and, I always forget how to pronounce his name. Dr. Wilgerner.
I would ask the court to allow the state to put on Dr. Veal for an offer of proof.
Sure. Go ahead, Colin.
We also have Brandon McClanahan that's ready to testify as well. Does the court wish to take up Dr. Veal first?
Well, as to Mr. McClanahan, I don't know. I mean, I'm not sure exactly there was a particular objection, except that the point was that we had a discussion yesterday about Mr. Armstrong, and I don't know, and we limited what he could go into, for the simple reason that it wasn't relevant, most of the stuff the state was talking about there. I don't know whether that's any different.
Mr. McClanahan will testify that he spoke to Mr. Ellis the night of the incident at 9:20 over FaceTime call, and he will describe describe Mr. Ellis, the conversation he had with Mr. Ellis, and his demeanor and his mood.
That was 2 hours before his encounter with the officers.
And as we've mentioned before, defense experts have indicated that they believe Mr. Ellis ingested methamphetamine up to 4 hours prior to the incident.
Well, yeah, they also said as recently as 30 minutes.
Right.
They're not saying he ingested it 4 hours before. They said that the usage was recent. And we had Mr. Armstrong yesterday talking about, well, up until about 10:35 that night, he was fine.
The defense has put into issue Mr. Ellis' state of mind that night.
Well, his state of mind, right. State of mind is certainly an issue, but his state of mind at the scene, not his state of mind 2 hours earlier when he's in church.
No, because the defense has put into issue that ingestion of meth occurred hours before the incident. So that does put into issue.
I think they're not saying hours before, they're saying recently as maybe as little as 30 minutes before.
As much as 4 hours. So that does put into issue.
Is anybody going to say, I saw him use methamphetamine? So I can tell you exactly when he used it? So he's going to say, I didn't see it.
However, their experts will say, we believe, well, I believe that Mr. Ellis could have ingested methamphetamine up to 4 hours before the incident, and that does put into issue this in the hours leading to the incident. And this is why we're calling these witnesses to show Mr. Ellis.
You were going to call them before all that.
That's correct.
So it isn't because of that.
Well, it's a due part because of that.
State of mind at the time you had we wouldn't offer in a regular defense case that 2 hours before all this that the defendants were just fine.
Well,
Would we?
if the state put that into an issue, so they certainly can, but, this is what the defense is.
But Mr. Liu, look I have to tell you, I mean, I don't want to sound too impatient here, but it's strange credulity to have this as an issue when the state is not contesting, no one is contesting, that Mr. Ellis had a very large amount of methamphetamine in his system at the time of his death. That's why I asked yesterday of Mr. Nicolavo, is the state contesting whether or not he was intoxicated with methamphetamine? No. Then what is this going to tell me?
Because the impact, the effects of that amount is different on people, and it's different on Mr. Ellis.
Well, not according to Mr. Armstrong. But even that aside, that would be fine if you're going to tell me when, I suppose, Mr. Ellis took the methamphetamine.
And defense will suggest that it occurred up to 4 hours, as much as 4 hours prior to the incident.
Right, and as little as 30 minutes.
Correct. So that does put into issue how Mr. Ellis behaved with 30 minutes to 4 hours prior to the incident.
Without any baseline for when he took the methamphetamine, this doesn't tell me anything. For one thing, you take methamphetamine right this minute and you could be just fine until you metabolize some of it. So what's the time frame for that? And then as I continue to metabolize it, does that change things for me? Right? Maybe it's apples and oranges, but if I have a beer, what's that impact on me? If I have 12 beers, what's that impact on me? Well, I didn't have 12 beers at the beginning of this thing. I had 12 over some period of time. Now it takes longer to drink 12 beers than it takes this kind of level of methamphetamine to be ingested. I grant you that. But we don't know the method by which it was ingested. We don't know whether or not it was smoked or was injected or how it was taken, right?
Yeah, but that doesn't stop the defense from suggesting that Mr. Ellis was in some sort of meth-induced psychosis.
No, that's right, and it's not going to stop him because he was, in fact, under the influence of methamphetamine at the time of his death, and the state is not arguing anything different. That's why this point about what he was like 2 hours before is, as described by the defense, it's just mere character evidence. He's a good guy, and it's too bad this happened to him. And I certainly don't disagree with that, but it's got nothing to do with the experience that the defendants were facing at that moment in time on 96th and Ainsworth on March 3rd.
Yeah, the state would submit it's more than, it's not character evidence, it's not just character evidence, it goes to how he was behaving that night, how his reaction to the meth that he ingested showed that he wasn't in a state of meth psychosis that the defense is alleging. I mean, that's what the defense is alleging occurred that night. And this is evidence that he was not. Despite having that amount of meth in him, he was not in a state of meth psychosis.
It's irrelevant what he was doing 2 hours before. Besides, we also have testimony already, I believe, indirectly, but I guess from Mr. Ellis's mother and from his sister about the call that night, right? Which was apparently made at about the same time this call was made to this other person. So you've got that in there already. And as I say, given how minimal its relevance is, I don't see the point of it. Now, if you want to call Dr. Veal so we can have an offer of proof, I'll be glad to hear it.
So we'll call Dr.
Yes, sir. Doctor? Please come on forward right about here. And then we're going to have you raise your right hand to be sworn. Yeah, right there's fine. Solemnly swear or affirm that your testimony in this cause will be the truth, the whole truth, and nothing but the truth?
I do.
Thank you very much. Have a seat right there. Please state your name and please spell your name.
Good morning, Your Honor.
Good morning.
My name is Curtis with a C. Veal, V is in Victor, E-A-L.
Thank you. We're doing an offer of proof outside the presence of the jury, so don't let that confuse you. If we do have you testify a little bit later, I'll ask you to be sworn in and spell your name and everything all over again. I won't have lost my mind. It'll just seem that way, just so that the jurors will be able to track what we're doing. So, Mr. Liu.
Thank you, Your Honor. Good morning, Dr. Beal. What is your occupation?
I'm a physician.
And who do you work for?
I work for a Swedish medical group, part of the Swedish medical system in Seattle.
And how long have you practiced with Swedish?
I was with Polyclinic from 1990 until last summer, but United Health had purchased 85% of Polyclinic and wanted to cancel all their hospital contracts. So I had to retire after 32 or so years from Poly and join the medical group a little over a year ago.
Do you practice in a particular unit within the Swedish medical system?
For the past 12 plus years, I've been exclusively in the cardiovascular ICU at Swedish's Cherry Hill campus.
What are your day-to-day duties at the cardiovascular ICU?
I am an intensivist, primarily there, also pulmonary specialist. So I do internal medicine, pulmonary, and critical care. So in that setting, I work primarily as an intensive care doctor.
With regard to your being a pulmonary specialist, what is pulmonology just generally for us?
The study of and knowledge of the function of the respiratory system.
How long have you practiced in this area?
I have been doing exclusively pulmonary and critical care since completion of training in everything in 1986.
And are you board certified in this area?
I'm board certified in internal medicine, pulmonary, and critical care medicine. Yes, sir.
How many patients do you treat who experience pulmonary issues on a week-to-week basis?
My census is usually 12 to 14 people a day, and of those, I'd say well over half will have some degree of pulmonary limitation, hypoxia, retention of CO2, or both.
Where did you obtain your medical degree?
Medical degree came from the Medical College of Georgia in Augusta, Georgia,
And when did you receive your degree?
1981.
After receiving your medical degree, did you perform an internship and residency?
I did. I did my internship and residency in the University of Washington system in Seattle.
And did you perform a fellowship?
I performed my fellowship in Birmingham, Alabama, having a sister who was ill. I needed to get closer to home.
What was that fellowship in?
Pulmonary and critical care medicine.
Dr. Beal, have you served as an expert witness before?
Yes, sir.
How long have you been doing that?
Since the early to mid 90s.
What were you asked to do in this case?
I was asked to address what I thought the cause of Manuel Ellis's death was.
And did you take a look at this case from a pulmonology perspective?
Yes, sir, I did.
What materials did you review in rendering your opinions in this case?
I reviewed several levels of interview of multiple Tacoma Police Department personnel, as well as Tacoma Fire Department personnel, I think, as well as some sheriffs as well. In addition, background, medical history, et cetera, of Mr. Ellis. And it is a long list, and it's in my statement. I could read from that if you like.
For the purposes of the offer proof, I think we'll move
Sure.
forward.
Video and audio evidence, bystander observations, yes.
Dr. Veal, I'm going to ask you about the basic overview of the respiratory system, and do you have an illustration that will help you explain the components of the respiratory system for us?
Sure.
Can you take a look at Exhibit 564, please?
Do I come here? Or,
You should be able to see on your screen in just a second.
okay, thank you.
All right. Dr. Veal, would this illustration assist the court in explaining the respiratory system to the court?
Sure, yes.
All right. Can you go ahead and, I don't know if it's better for you to step down or maybe perhaps
Sure, is it on this screen as
it is
well?
on the screen. You're able to turn it so that the judge could see.
Yes.
And I think there should be a pointer here somewhere near you.
Use this.
Okay.
Yeah.
That'll work out.
So
Settle for that.
the respiratory system per se starts in the upper airway
And goes down through the trachea with main stem bronchi branching into lobar bronchi, branching into bronchioles that ultimately terminate out in these little air-filled sacs called alveoli. They're microscopic. These airways have, you know, your trachea, you can feel it right here. It's got substance, but this is a very spongy material. And there's this beautiful interaction between the heart and the lungs. With your heart here, the right side of the heart is pumping blood that doesn't have oxygen yet, depicted here as blue, and it capillary bed coats that alveolar surface so that as that gas goes through those capillaries, it becomes oxygenated, which is depicted in red, returns to the left side of the heart, and then it's pumped out to the rest of the body. So to do that requires that we have these structures in place and chest wall and diaphragm muscular activity to help create a vacuum and inhale the gas into our chest and then exhale the gas out. The exhalation is more passive than the inhalation.
You mentioned the diaphragm. What part of that illustration shows the diaphragm?
One of the leaves of the diaphragm is depicted here and the other one here. There's no depiction of the chest wall on this diagram.
Okay. And you mentioned the mechanics of the breathing. Is there an illustration that would help you explain the mechanics of breathing for us?
Sure.
Can we have Exhibit 565, please?
So when we inhale, we generate negative pressure in our chest, and that happens due to a couple things. The diaphragm is this muscle that contracts and becomes, for inhalation, this is about as flat as it'll get. And at the same time the diaphragm goes down, the ribs come up, which is why if someone's laying on their back, you'll say their chest is rising and falling. And what's happening is those ribs are literally swinging up and out, and you can't see it from the side, but the sides are going out as well. Then when we exhale, we exert pressure on the diaphragm, which expels gas from the lungs, and at that same time, the rib cage, many of us think of a skeleton here on Halloween as being, having horizontal ribs, but our ribs are really diagonal like this. So when we inhale, they become more horizontal. When we exhale, they become more downward pointing. And so both of those mechanisms are required to adequately ventilate.
And when you're explaining, Dr. Veal, the sort of the movement of the ribs, is there a pump handle action, the weight,
Sure.
bucket handle description that you use?
Yes, if you would go to the next
All right.
diagram.
If I could show you Exhibit 566, please.
So we do refer to that anterior posterior, the part where when I breathe in and my ribs come up a little bit and my chest becomes thicker from back to front as a pump handle motion. And that obviously requires the sternum and the ribs to be able to swing up. At the same time, the lateral ribs are coming up in a more of what's described as a bucket handle movement. This can't happen without this being possible. So if there's an inhibition of the ability to elevate those ribs, you're not going to be able to pull in air by use of your what are called accessory muscles of respiration.
Okay. So if someone is in a prone position, gets a hard surface, would that impact his ability to?
It would impact, yes.
Okay. Are you familiar with the term prone positioning?
I am.
What does it mean?
It means lying on one's stomach.
And can prone positioning affect someone's breathing?
It can, yes.
And how so?
Well, if one is lying on one's stomach and is very obese, the pressure of the abdomen itself can push up so that if you remember that diagram, the abdominal contents push up on the ribs, up on the diaphragm, and you can't inhale quite as easily that way.
Would those effects on breathing be impacted by adding weight to someone's back when they are in the prone position?
They would.
And I'm going to show you Exhibit 567, please. And Doctor, does this exhibit help you explain that concept?
Yes.
Okay. Can you explain for us then
Sure.
how the pressure on the back impacts?
So my subject here is laying face down and has a firm surface underneath him or her, and has to, lift their body weight with those accessory muscles. The diaphragm becomes a little more difficult to contract because of that abdominal pressure, which would be greater the more obese one is. And then if those things alone have been studied and been shown to impact the ability to breathe somewhat, but when you place, but not in a fatal way typically, when you place pressure on a person's back, making it even more difficult for them to elevate those ribs, the pump handle, the bucket handle motion, that further inhibits their ability to ventilate backward.
Based on your review of the materials in this case, how does the discussion of prone positioning relate to Mr. Ellis' circumstances?
Well, he was described as being in the prone position. First of all, he was first encountered at 21 minutes after the hour. An altercation then ensued. And
Dr. Veal, I'm going to have to go ahead and, if you're more comfortable sitting down.
Yeah, sure. Altercation ensued, and officers Burbank and Collins were attempting to restrain him for safety, and they were having a difficult time. when officers Rankin and Ford arrived 3 minutes later at 24 after the hour, plus minus some seconds, Officer Burbank was sitting on his back, and he was still trying to move at that time. Officer Rankin quickly offered to render any assistance he could to them to help restrain him. And so basically they got hobbles from that point forward, placed hobbles, connected them to handcuffs in the back. And once Officer Burbank got off his back, Officer Rankin assisted by getting on his back, putting his knee up at the base of the neck and another knee in the middle of the back. This is by his description. And he was there for a period of time that I can't quantify.
Does positioning the knee on the base of the neck and on the lower back impact Mr. Ellis's ability to breathe based on what you discussed?
I think that would more effectively compress the chest and its ability to raise those ribs up, and the diaphragms and their ability to, expand the lungs.
And based on your review of the materials, do you have an understanding of how long Mr. Ellis or how long Mr. Rankin was in that position until fire arrived?
Well, from the time of Officer Rankin's arrival until fire's arrival was right at 10 minutes, from 24 after the hour to 34 after the hour. We know that Officer Burbank, by Officer Rankin's description, was sitting on his back when he arrived, still moving. Officer Rankin assumed the position I mentioned after Mr. Ellis seemed to be not, as they describe, resisting, struggling to breathe, trying to get up. He was placed in a recovery position as described in the records that I reviewed. He then became violent by their description again and was returned to the prone position. And by my review of the records and descriptions of others, he was in that position until the arrival of the fire department or until they were on physical approach walking from the rig to the site.
You described a little bit of the struggling. Does air hunger sound familiar to you? The concept of air hunger, are you familiar with that?
Yes, sir.
What is that?
Air hunger is when, pardon me, when any of us have a sense of shortness of breath. It is extremely distressing to most people, more distressing than pain or nausea to most people, a sense that you are smothering, if you will.
Can someone speak and still be unable to breathe properly?
Yes, sir. Provided they've been able to take a good deep breath, they'll have enough gas, or air is a gas, they'll have enough gas in their thorax, in their chest cavity, to exhale, because speaking, singing, yelling is all a matter of exhalation of gas from the chest against vocal cords that are vibrating at a certain frequency to make the noise like I'm making right now. So yes, you could continue to speak repeatedly until you had no more gas in your chest, unless you were able to freely take another deep breath, but you would run out of the ability to do that.
What is hypoxia, doctor?
Hypoxia is a level of oxygen that's not sufficient to allow normal cellular respiration. Our bodies run on fuel, which it consists of carbohydrates, protein, and fat, primarily glucose. And to burn that fuel, you got to have oxygen.
What kind of symptoms might be common to see with someone who is experiencing hypoxia?
Agitation, nonspecific agitation, an appearance of panic, possibly struggling to raise themselves up to get that pressure off in order to take a deeper breath. And in more extreme cases, which wouldn't be the case in this circumstance in the dark with a dark-skinned individual, but with many people you can see them become gray or ashen and or get blue around the lips and tongue, but I'm not implying they could do that in this circumstance.
In reviewing the medical evidence and reports from the scene, did you see evidence that Mr. Ellis was suffering from hypoxia prior to his death?
I did.
What did you see?
Well, what I saw was this. Officer Rankine very nicely outlined what happened, and he describes having turned him to his recovery position, which I don't remember whether that was right or left, lateral, laying on which side. And at that time, he took his pulse and was appropriately surprised to find that it was 80 beats per minute, which is abnormally low for a person who's been through an altercation like that and just barely been subdued. He's got things that would increase his oxygen demand, including the meth on board, including the altercation itself, including the taser applications, and those things would increase his oxygen demand. And so that 80 beats per minute tells you that he's not having a normal cardiac response to exercise even then. And then when the paramedic Wilson arrives, he finds him to be bradycardic, and ultimately he loses electrical impulses altogether.
You mentioned the recovery position. What does it mean to place someone in the recovery position?
Well, I'm going to concede that I learned of recovery position in looking at this case. It sounds as though it is placing the individual in what we would call a right lateral decubitus, which would mean me laying on the floor on my right side, or a left lateral decubitus position on my left side with little pressure on my anterior chest.
Can the recovery position be useful to assist someone who is having trouble breathing while restrained?
Yes, sir, it can. If one has an intact brainstem with intact ventilatory drive, and if one has not developed hypoxia to the point that the heart itself is not pumping effectively, the individual should be able to resume breathing more easily now that the pressure is off. But it would require those things to be present.
And are you aware whether Mr. Ellis was placed in the recovery position prior to EMS arrival?
I understand he was placed in it at least once, and the once that I saw described was met with him sort of beginning to move around again, and so he was then placed in the prone position again, where I believe he remained until the E10 rig firefighters were approaching from the rig, at which point he was placed in the recovery position.
Why did Mr. Ellis recover after being placed in the recovery position at that point?
I think that by the time that happened, he had already become completely unresponsive, and it was affecting the perfusion of his brain, and he did not any longer have a normal ventilatory drive. His heart was probably also not working normally at that time.
And are you familiar with the medical interventions that were performed on Mr. Ellis by EMS?
I am.
And what are they?
Well, upon arrival, on approach, paramedic Wilson described that he was still breathing, perhaps, but he was clear that it was ineffective. By the time they got his clothing and restraints off, he was described as apneic, which is not breathing at all, and bradycardic.
And if respiration-based therapies like the BVM and intubation do not resuscitate someone, does that mean they don't have a respiratory problem?
No, no. So I should have gone on to say they quickly placed an intravenous catheter to allow administration of medications. They quickly began bag mask ventilation with an oral airway in place, and they didn't describe any difficulty with that, meaning sometimes you can't actually ventilate. People have sort of a swollen airway or whatever, but that was not described. So they placed the IV, they put the bag mask on him, and ultimately intubated him, which is a more reliable way of being able to push the gas in and out of the chest. They administered, once he completely arrested and they lost perfusion entirely, he received CPR, and I think 7 milligrams of epinephrine, some lidocaine, and some bicarbonate, sodium bicarbonate.
Dr. Neal, going back to the concept of air hunger, when someone's experiencing air hunger, what do you expect to see from the individual?
Well, this is not in front of the jury, so I don't really worry about that, but I think he already did say that there would be, that the experience of a shortness of breath is distressing to the person experiencing it, and that they would begin to be agitated, they would appear to be panicked, they would appear to make an effort to raise up in order to get deeper breath, and a couple other things like being cyanotic and so on, but he said that wasn't necessarily evident here one way or the other. Right? Did I miss anything?
Yeah, I think you covered it.
And Doctor, were you asked to form an opinion on Mr. Ellis's cause of death in this case?
Yes, I was.
And what is your opinion?
Looking at the differential diagnosis, which is the multiple possible causes of death, realizing that one cause that was contended was that it was the methamphetamine toxicity alone that caused his demise. I looked at his cardiac health leading up to this. I looked at the autopsy findings. I looked at all of the facts of the case, and his demise was most consistent with a hypoxic and likely acidotic environment that did not allow his heart to function normally.
Dr. Veal, one more question. Can you explain what happens when each time someone expels breath with "I can't breathe"?
Right. If you have filled your lungs to capacity with a good deep breath, it's going to take approximately 100 milliliters, which is a little over 3 ounces, 3 to 4 ounces of air per breath to say several words. And so you've got a chest full of air, and you could say those several words multiple times until you no longer had any gas in your chest. And then if you were to keep speaking, you would require an inhalation of gas, because you have to have the gas in here to come out through your vocal cords and make a noise.
Did you see that here in this case, or see evidence of that?
I saw that he was able to phonate that he couldn't breathe, audible from the camera across the street, 5 times during this period of time, yes.
Nothing further on.
Any cross on the offer proof?
You'll take it. But none from the either, but I have a couple of questions.
Go right ahead.
Good afternoon, Dr. Field.
Good afternoon.
We haven't met before. My name's Mark Conrad. Our office represents Officer Rankine here. Do you have a copy of your report?
I don't with me, no, sir.
So this is Exhibit 506, and I wanted to hand you a copy of this report. And that's the report you authored in this case, right?
Yes, it is.
Okay. And so one of the things that I wanted to ask you about was this hypoxia that you've discussed.
Yes, sir.
You would agree with me that there's no anatomical finding that you could point to that evidence is hypoxia. Do you agree with that?
That is correct.
Okay, so there's no like oxygen saturation level that you could point to, right?
They were never able to obtain one.
And so you've looked at the facts of this case, or I guess what the statements say, right?
Yes, sir.
And then this is actually your first prone restraint case, is that right?
This is the first criminal case I've ever been involved in. It's the first prone restraint case as well.
Okay. And so you looked at the facts, you reviewed the literature on prone restraint, correct?
I did, yes, sir.
And then you looked at the medical evidence in this case as well. Right?
Yes, sir.
And one of the things that you noted in your report, right, is you talk about his cardiac health.
Yes, sir.
You talk about the idea of having a cardiomyopathy in his left ventricular hypertrophy as well.
I talk about it in the context of his normal structure and function a little over 2 years prior,
Okay.
and the fact that even exposed to meth for 2 more years wouldn't cause a diminution of cardiac function from completely normal 2 years ago to the point that he was suffering from a significant cardiomyopathy.
Okay. You didn't feel that he had significant cardiac issues?
He had minimal but real thickening of the left ventricular wall, which is not normal. He had no evidence of any residua from the pericarditis he had had several years before. His pericardium was normal. His right ventricle and right-sided tree looked normal.
The other thing that you talked about was the role of methamphetamine in your report as well, right?
Yes, sir.
And you stated that Mr. Ellis's toxicology results fell within a recreational use range. Is that right? Is that what you stated?
I said because I found that term a little amusing. It was from the National Highway Traffic and Safety Administration, but they did refer to recreational meth use, yes.
Okay. And then ultimately, your opinion really relies on the fact that you noted that Mr. Ellis suffered a PEA cardiac arrest, right?
Well, Paramedic Wilson clarified a little bit in his testimony that he was perceiving some pulse up until the time that they began CPR. So what I can say is he had progressive bradycardia, as witnessed by the pulse of 80 when first placed in the recovery position, followed by less than 60 when encountered by paramedic Wilson, followed by complete arrest. And that is almost certainly due to hypoxia.
Okay. So, and I guess that's what surprised me a bit, I guess, by this offer of proof is you never once mentioned PEA, cardiac arrest, right?
No, sir.
Okay. And then, but in your report, you focus on it a significant amount, right?
I discussed that, and it also would be manifested by progressive bradycardia.
Okay.
But yes,
Well, they're two different things, doctor. I'm asking
They
you
are.
about PEA, cardiac arrest, not bradycardia.
that's correct.
Okay, let's stay on the same page here. So the PEA, so you focused a significant amount on PEA cardiac arrest, right? And you did so in your defense interview as well.
I focused on progressive bradycardia
Okay,
as well.
okay. So are you changing your opinion that this wasn't a PEA cardiac arrest?
Having reviewed paramedic Wilson's description from his testimony, I don't have good evidence that it was PEA arrest. I will say, when he initially encountered him and called his heart rate bradycardic, and you look at the strips, and there are times that if you looked at two of those complexes, they would be equivalent to 30, 40 beats a minute. But then there'd be several that were closer together, consistent with more like 100, 110 beats per minute. And so based on his description that this was bradycardia, and the fact that he was feeling the pulse with those electrical signals, it implied to me that he wasn't getting muscle contraction from every one of those electrical signals, or he wouldn't have been described as bradycardic initially.
So the other thing that you talked about just now in your offer of proof was you indicated that you talked about Officer Rankine putting pressure on Mr. Ellis's back, right?
As described by him, yes.
Okay. And you said that you felt that I mean, is it going to be your testimony that you think that took place for about 10 minutes?
It couldn't have been quite 10 minutes because the first minute or so after Officers Rankine and Ford arrived on the scene was spent assisting Burbank and Collins in establishing the restraints. And it was only then, and I don't have a timestamp on that Officer Burbank got off of his back where he was described as being seated, and Officer Rankine took over with the pressure on the back in the prone position. Yes, sir.
Okay. So I guess my question just with you is, you don't know how long Officer Rankine was on. Let me finish the question, please. You don't know how long Officer Rankine was on Mr. Ellis's back. Is that correct?
That is correct.
Okay. And you don't know how long Mr. Rankine was also in the recovery position as well, right?
Mr. Ellis was briefly in the recovery position before he behaved in a manner that prompted them to put him back prone. And apart from that, by descriptions of several officers, he remained in the prone position until the arrival of fire at the scene. Was placed in recovery position maybe as they were on approach from the rig. I think that observation might have been made by Officer Farinas. I'm uncertain.
You said briefly, and so he's in the. Is it your understanding that Mr. Ellis is in the recovery position once or twice?
The second time right as fire was arriving.
Okay. And the first time, do you know how long?
I do not know how long. It sounded pretty immediate in their description, but I do not know how long.
Okay. And when Mr. Ellis is placed back into the prone position, does Officer Rankine ever describe putting all of his body weight on top of him?
He actually did, and then later modified that he had, at some point in all that, had one knee on his back and a knee on the ground. But he did describe placing as close to, if you have your toes still on the ground, that's not going to be your full weight necessarily, but a lot of his body weight on the back.
But you don't know how much body weight.
I do not.
Okay. So just kind of summarize. I mean, you'd agree with me if your opinion is based on weight of an officer on his back, right? Is part of your opinion.
My opinion is more based on progressive bradycardia leading to the complete arrest and looking at things that could cause that. Why would that occur in this setting? And the only explanation I can come up with is that, yes, the addition of the weight pressure to the back was enough to decrease his ability to adequately ventilate and oxygenate.
Okay. But you don't know for how long.
I do not.
You don't know how much.
I do not.
Okay. So when you mentioned 10 minutes in the offer of proof, were you saying, and correct me if I'm wrong, I haven't had an opportunity to look at the transcript yet, were you saying that my client was on his back for 10 minutes, or that was just a number that you pulled out?
As I said, officers Rankine and Ford arrived on the scene at 24 minutes plus some seconds after the hour, and the fire department arrived, which is when he was, when they started the resuscitation attempts, at 34 after the hour, and I did the math on that. But what I already said also was that Officer Burbank was seated on his back upon arrival of officers Rankine and Ford, and that Rankine took the place of pressure on the back only after getting his wrists and ankles secured behind his back, is my understanding. So that would have taken some time, obviously. I don't know if that was 1 minute, 2 minutes, or what.
Okay. Thanks, Jay.
Any further?
That'd be clear.
I've got a couple of questions.
Yes, sir.
So, Doctor, you understood that at this point in time when Officer Rankine is on Mr. Ellis, that Mr. Ellis's arms and legs would have been behind him?
Yes, sir.
Did that, the fact that the position of the legs and the arms would be, in a sense, in the way for fully being on somebody's back, did that play any role in your analysis?
No, sir.
Okay. You did mention a moment ago that Officer Rankine had, at least at one point, only one knee on Mr. Ellis, which presumably at that point was in his low back.
That is true.
How would that have impacted Mr. Ellis's ability to breathe, just that part of it?
Again, I don't know how much weight was being applied to the back with that one knee.
Okay. Well, if you knew it was 10 pounds or 40 pounds or 100 pounds or some number, would that how would that play into this? I mean, obviously, 100 pounds is more difficult than 10.
Yes, sir.
But beyond that, do we know much?
We don't. The only data we have in that area is that if you apply 30% of the individual's weight, not Officer Rankin, but
Mr.
the
Ellis?
subject, and which would be roughly, what, 60, 70 pounds, that alone wouldn't be fatal. So it had to be more weight than that.
Okay. And let's assume that for just a moment that it was more weight, let's say it was 100 or so, or even more. How much time would it take in that position, in that circumstance, with that much weight on him, to lead to a point where Mr. Ellis would be, it would be too late for Mr. Ellis to recover? Do we know?
That's a great question. It would take approximately 4 minutes for him to lose consciousness, and a very short time after that to begin to have such low perfusion of oxygenated blood to his brain, to have his ventilatory drive begin to decrease. Recalling paramedic Wilson's description of inadequate breathing, as he described it, as he was approaching him before he developed complete apnea.
Would somebody with Mr. Ellis's conditions at the time of this event take less time to succumb to hypoxia than somebody else without those problems?
Without the meth plus the physical exertion plus the taser,
And the heart condition?
his heart condition would only impact his oxygen demands in that his ventricular wall is a little thicker than normal, the upper limit of normal being 15 millimeters, and it was described as 15 to 18. We see ventricles up to 30 millimeters thick, where people
Sure.
are doing okay, if not stressed.
Well, of course, he was stressed, so.
Yes, he was.
But that was my point, that we did have some testimony, I believe, from other witnesses that suggested his heart condition would play at least a role. And so that's why I included that. But yes, the methamphetamine, the taser, any obesity potentially, although I don't know to what extent Mr. Ellis was to be considered obese, his heart condition. So he had all those factors at the time this was happening to him. So my question would be, somebody in Mr. Ellis's circumstance, would it take less time for him to succumb to hypoxia than somebody else who was a 32 or 33-year-old similarly situated adult without those problems?
Because of his increased oxygen demand based on the 3 factors I already mentioned, then that would cause him to be more susceptible to hypoxia, because his body is already needing more oxygen than that otherwise healthy 33-year-old who just laid down on their stomach.
And I think you kind of answered this a little bit, and sort of the thing we talked about here a moment ago would have to do with what the appearance of somebody like Mr. Ellis would be once he has an issue with having a loss of air. But as you were describing that, it seemed those kinds of things, agitation, appearance of panic, his effort to get up, would be all the same things that a police officer wouldn't want a suspect to do, right?
Wanting to get up,
Yeah.
right? I understand.
So those things that we would expect Mr. Ellis to naturally do when he can't breathe would be the very things that the officers don't want to see him doing, because they're trying to control him.
They're trying to get him not to struggle.
Yeah. So if he was at a point where he was losing consciousness, which I think you talked about a moment ago as being one of the things that would be an indicator, that once he loses consciousness and then a short time after that, he would have some difficulty breathing. If he had not, until he loses consciousness, how would somebody in the police officer's position know that Mr. Ellis was facing an extreme medical condition?
I only know that he became, he stopped moving minutes before the arrival of E10.
The medical guys.
Yes, sir. So at that point, I think he was at a point where if he had been immediately by some miracle placed in recovery position and begun resuscitation with other things which might have included brief ventilation and CPR, he might have been recoverable at that point when he just passed out.
Okay. Which would have been, your estimate is that was a minute or two before the...
It was at least a minute or two, yes, sir.
And now you indicated that you had, I guess, reviewed the testimony, I guess the transcript of Lieutenant Wilson.
I did.
Did you also get a chance to review the testimony of Doctors Mitchell and Wolgernetner?
Yes, sir, I did.
How would you distinguish your testimony from those two doctors? How is it different?
I think it more specifically speaks to the mechanism by which the hypoxia that we're talking about would occur. I haven't seen that well described, but that's the main difference I would see.
Okay. Anything else based on my questions, Mr. Liu?
Just briefly,
Yeah.
Your Honor. Doctor, you were asked by the court whether you saw, well, whether there's evidence that Mr. Ellis was struggling or indication that he was in trouble. What about that? I can't believe. I mean, is that an indication that he's in some distress?
Of course, yes.
That's all.
But with respect to that, let me ask a question too, because it was something I was thinking about. Mr. Ellis was saying, I can't breathe before, for instance, Officer Rankine got there.
Mm-hmm.
And he was saying it loud enough that it got picked up on the video across the street.
Yes, sir.
At least in a couple of questions the defense has suggested here at some point, it may well be that Mr. Ellis was saying that as a way to get the police officers to back off. Did you get the sense that this could have been a ruse by Mr. Ellis, at least at one point in time, and maybe genuine at another?
I cannot argue with that possibility,
Yeah.
Your Honor.
Okay. I won't ask anything else. Anything further from the defense? Mr. Liu? Okay. Thank you, Doctor. I'll have you step down for a few minutes and
Yes,
step
sir.
outside, and we'll may have
I
you
will.
back here.
Thank you, Your Honor.
You're welcome. Thank you. Nice to meet you.
Nice to meet you. Exhibit goes.
Oh, you can leave that with this lady right here. Okay, Mr. Liu, is this cumulative?
No, Your Honor, it's not cumulative, as Dr. Gill himself indicated. He's describing the mechanisms of the hypoxia in the context of the pulmonologist and how the position of the defendant impacted his ability to breathe. And he also talks about other things, such as being in the recovery position, why he doesn't able to recover. And he's offering plenty of other information that was unique and not covered already by other experts.
Your Honor, both Dr. Mitchell and Dr. Waldner testified almost identically to what Dr. Beal's testimony. So there's nothing new by this particular witness. It is absolutely cumulative in the court should allow, and there's nothing more I can say.
Defense for Officer Collins? Okay. By nothing to add, does that mean you have no opinion one way or another, Mr. Osler, about whether or not this witness should testify?
He's actually very helpful to my client, so there's part of me that wants him to testify.
So you're not joining?
Well, it's certainly cumulative, Judge. He's testifying to the same thing Dr. Mitchell said, the same thing Dr. W. said, the same thing Dr. Clark's going to say, the same thing Dr. Smock's going to say. So he doesn't add anything other than he basically exculpates my client. So I want that part.
So you may call him in your case.
I may, I guess.
All right, so I'll mark you as not joining this motion.
Fair enough.
Mr. Conrad?
I mean, Judge, the same issues I initially raised with the court is, first, I think it's cumulative. I think that he says much of the same things that Mitchell and Dr. W. say. He even talks about the idea that because Mr. Ellis is fighting and doing push-ups or trying to get these officers off of him, that's him struggling to breathe. We've heard that exact same testimony from those prior experts. He's now changing his testimony, I think, significantly from what he said in his initial report and in his interview with us. But that doesn't change the conclusion that he's coming to, which is the same conclusion that Mitchell and Dr. W. testified.
The change being this PEA business?
Yeah, he talks all about PEA, and he talks about there not being a pulse upon arrival of EMS. And I've been wondering this whole case where they're getting that from. I mean, and some of the
Well, wasn't that Dr. Wolgerner's initial
it was.
view?
It was.
So that's maybe where he got it.
I mean, that's not. If you actually read the interviews, though, of Lieutenant Wilson, I mean, the state would have impeached him if that was not true, and they didn't because he's been consistent. So he said he had a pulse the whole time. I mean, that's why I brought out the fact that, look, when he does CPR, you just think he's sitting there for 4 minutes without a pulse. That's ridiculous.
Mhm.
So, he talks about him not having a pulse and that it being PEA, cardiac arrest, and that's why it's hypoxia, and that's why he deduces that it's because of what the officer did to him. I think, that an expert can use foundational material, but what they can't do is they can't manipulate it to fit their version of events and fit the state's version of events. And that's not only what they're doing with this pulse business, which now is just flying straight in their face in front of the jury, but they're also trying to do it with manipulating what my client's saying, right? He doesn't, first he says 10 minutes. I mean, I heard 10 minutes that my client was on him. And then he backs off because he knows we have him on record saying, I don't know, and I don't know how much weight, and I don't know how long he's in the recovery. And that's what he's basing his opinion off of, because otherwise he'll say restraint positioning alone doesn't cause hypoxia, won't kill you. Well, you can't say that you can't just come to a conclusion and then determine and manipulate the facts to fit that conclusion by saying, well, I know that he had his full body weight on him for 10 minutes. Well, that's not what he says. That's not what my client says at all. And I think that it's completely disingenuous to put that testimony in front of the jury. Not only is it cumulative, like I've said, but I think the foundation for it is fundamentally flawed. And then, on top of this, I guess he's steering clear from the toxicology issues because he's not a toxicologist and he doesn't have the statistics to prove that. He's talking about the same cardiac issues, but all of a sudden this expert's saying it's normal, which my memory of the previous experts was that it's not normal. It's not a normal heart. It is a cardiomyopathy, and he's trying to say no now. So again,
Well, I think what he was saying was it wasn't a normal heart, but it wasn't so abnormal as to be a contributing factor here, or at least a significant one.
well, to that extent, then it's the same testimony that Dr. W testified to and Dr. Mitchell, because that's what they said. They acknowledged that it wasn't a normal heart, but that it wouldn't have caused the death. So he's saying the same thing.
Well, we learned something, at least from my couple of questions. I don't want to tap myself on the back here because I'm not necessarily trying to advocate for anybody, but I didn't know how much body weight it might require. Nobody's asked the question of any of the other doctors. He suggested it had to be more than 30% of Mr. Ellis's body weight. That was new information. And I asked about how much time would it take for somebody to be beyond the point of being able to recover. And he talked about a short while after a loss of consciousness, assuming he lost consciousness because of a lack of oxygen.
I don't know where this 4 minutes is coming from. I don't think there's anything to support that. Maybe he's talking about from like complete asphyxia, but
I think that's what he is saying. Because
And like-
because if you're getting some amount of air, I suppose you're not going to become unconscious compared to as rapidly as compared to a complete loss of air. But
so the 30% is enlightening, but it's only enlightening if you know what the percentage is or what the weight is that's actually applied to him, right?
well, yeah, but then there is that possibility of discussion.
I mean, to the extent that I mean, I don't know where the foundation for that comes from. I don't know what from this 2021 article, Campbell article that he relies on. I mean, other than that,
My basic concern is whether or not this was really anything new, and I'm not sure that it's much new. The doctor himself has said, well, the biggest difference between me and the other two doctors was that I'm explaining in more detail and more specifically the mechanism involved when adding weight and positional complications to this inability to breathe. But it wasn't so much that wasn't testified to as that he's elaborating on it. Mr. Liu?
Mr. Conrad sort of mischaracterizing what Dr. Neal said. I mean, he was asked about the 4 minutes during his defense interview, and that was brought up. How long does it take for someone to go unconscious? And
I wasn't aware of that.
Dr. Neal's report actually addresses what we're trying to get at from his testimony. That is with regard to the respiratory issues and how being in a prone position will lead to that, and the mechanics of that. And that's what's contained in his report. That's a major part of his report. And that's what we want to bring out from this Dr. Beal. This is something that the other experts do not cover in detail. And this is a pulmonologist that's able to offer this to the jury.
Well, I don't know that makes a difference. Does defendant Burbank have a position on this?
You already said it's cumulative. I mean, it's cumulative to what the other experts have testified.
So you think we should exclude the doctor?
I think we should. Just that he doesn't add anything to the puzzle.
Mr. Oster thinks we should not exclude the witness.
Well, kind of, Judge. I think you should be excluded, but there's certainly benefit to me if you don't.
And I think I know where Mr. Conrad is. Well, this is very marginal. I mean, I really hate to sort of exclude a witness, but it doesn't add much to what we've heard. It really is just the same thing over and over again. And yesterday the state was complaining about cumulative evidence. Now they're offering it. You can shake your head no, but Mr. Liu, but you're not doing a good job convincing me, at least, that this is anything different from what I've already heard.
Again, I stand to submit that Dr. Beal, as a pulmonologist, is rendering his opinion from a unique perspective that's different from the pathologist or a cardiologist.
You know, but that, just bringing in a different person with a different, you know, experience level, whatever, saying the same thing as two other people who have different experience levels too. I mean, there was an issue about whether Dr. Mitchell should testify at all, given Dr. Clark's on the witness list for the state. You know, I didn't blanch at that particularly, even though this defense wanted me to exclude him for the same kind of reason. But how many times are we going to do this? You avoided any of the statistical stuff, and I
Yes, Your Honor.
appreciate you're not going to offer that.
But I should point out, Your Honor, that, you know, the positional asphyxia is an issue, is a controversial issue that, you know, Dr. Veal would be able to offer an opinion on, and this has been brought up, and this is an issue that both the defense and the state, you know, are litigating. And so, yeah, that is an issue that's important.
And just to clarify that the defense actually raised that with Dr. Mitchell. They asked him specifically that in an article that it discusses the controversial nature of the idea of positional asphyxiation. So again, we're talking about an issue that's in controversy in this case. The defense wants to say positional asphyxia doesn't exist, and Mr. Ellis didn't die as a result of hypoxia and the positional asphyxiation. So I think on the balance, when the court's talking about
How many lawyers are arguing this motion? Dr. Wilgertner had said this, was asked the same question and conceded the same thing.
Correct, and I guess I'm just pointing out to the court that those are issues that the defense is challenging. So to say it's cumulative when they are challenging a fundamental issue here about the way that Mr. Ellis died is, on balance, we would suggest mitigates against the idea that it's cumulative.
Well, I agree with you in general that the idea that something that is highly controverted in the case is one in which we may well take evidence that might otherwise be regarded as cumulative. But I'm also of a mind that you've got Dr. Clark is also going to say the same thing. And we're not going to exclude him since he was the one that actually conducted the autopsy. So, and I don't know whether or not you've got anybody else who's going to say this. Do you?
Dr. Smock.
Is Dr. Smock from Lincoln?
These are not the exact same issues, and you know, with respect to Dr. Clark, I guess, you know, the defense could call him as well, right? I mean, if the state didn't call Dr. Clark because Dr. Richards already testified, and it would be considered
So are
cumulative.
you saying that the state is no longer going to call Dr. Clark?
I never said whether we were gonna call him or not, Your Honor.
Oh, that's news to me, Ms. Eakes, quite frankly.
I can't speak at this.
Wasn't he on your, was,
Multiple people,
okay. Was he not on your witness list?
He and every one of these people is on our witness list. All of these folks are on our witness list.
Yeah.
And if the court finds that cumulative is an issue, then obviously the state needs to make decisions with respect to who we're actually going to call. That's, I mean, this is the concern. I mean, if the court's gonna start saying that things are cumulative, then we make decisions.
I'm going to start saying this?
Well, I think the court has said that, and now you're.
Well, I've got an objection on that basis.
Well, understood.
Now I've got to deal with that, and then I have to either agree or disagree. I see a lot of things that are cumulative about this, and as I say, even Dr. Veal conceded that substantially his testimony is the same as those two, after he reviewed their transcripts.
You're talking about the ultimate opinions. I think what's important.
No, I got the impression he was talking, I asked him, well, how does his opinion differ from, or his testimony different from the ones that we've received already? And he talked about not the fact that they're the same conclusion. He talked about the fact that he had described this mechanism in a slightly more elaborate way, but not that anything else was different about it.
Correct, and that's even if the court allows us to put him on for that purpose, not ask him about his ultimate opinions, but ask him about the mechanism and the exhibits, the illustratives that we did, that it's helpful to the jury to understand the breathing mechanism.
Okay, I need to know right now, though, are you going to withdraw Dr. Clark?
Your Honor, I can't answer that question right now. because I have to process what the court has said today. Just like yesterday when the court let us know that you're not going to allow us to call other people that had contact with Mr. Ellis in those hours leading up to the time that he had contact with the defendants. That's causing us to adjust, obviously, because if the court has that view that that's not relevant or that other things aren't relevant with respect to the whether or not things are going to be called cumulative, the state has to make decisions with respect to what witnesses we can then call.
Well, when we were arguing about Dr. Veal last July, this was the very issue. I read it from my notes. We shouldn't allow Dr. Veal to testify because, this is a defense, we shouldn't allow Dr. Veal to testify because they're going to have Dr. Mitchell and Dr. Clark who are going to say the same thing. Those were the notes I quoted back to you earlier this morning from the July hearings. I mean, this is not a surprise.
Understood. And we didn't know exactly how the court was, we understood the defense was going to raise the issue of cumulative. We didn't know how the court was going to view with respect to whether you determined things were cumulative, when from the state's perspective, Dr. Veal is a pulmonologist. He is addressing the issue like that testimony with respect to just understanding the mechanisms as he walked through with his illustratives of how breathing works, helps the jury understand how hypoxia happens from the restraint and the pressure that was being put on Mr. Ellis here. And that's the difference that the state has always tried to articulate to the court that explains the difference between them. With putting aside the whether he makes, you allow him to offer an opinion as to whether or not, as to how Mr. Ellis died. That's what the state thinks that it adds with respect to the jury understanding the science and the evidence that they've heard so far. Much in the same way that Dr. Wardelerger was able to discuss the cardiac issues. As the court knows, pathologists are generalists in terms of what they look at. And that's different than those who have specific knowledge with respect to lungs and heart, which are an issue in this case.
But I guess I would have to say that the idea that it's harder to breathe when there's a weight on your back than when there isn't one is something of fairly common knowledge. It doesn't require a pulmonologist to tell me that. I only have to remember my brother sitting on my back as a child.
I don't disagree, but it is disputed by the defense as to whether or not this is actually anything that could have injured Mr. Ellis.
It's apparently disputed in the medical community to what extent it could cause the death of somebody.
Correct. But nobody's conceding on the defense side that this is an issue that isn't in dispute. So
No.
again, we're talking about the issues that are in dispute
Of-
that the jury needs to be able to sort.
Of course they're not. Yes, Mr. Conrad.
One of the biggest things I think that's problematic again with this is, aside from the cumulative nature and the fact that I'm hearing that Dr. Clark may not be testifying, which raises some big confrontation issues, is the way that the state's experts are laying down their foundation for their opinions as well. Like, not only are the opinions cumulative, but then the way that they manipulate what's being stated, and not even manipulate, they're just making them up. Like, to state that he's on his back for 10 minutes, which is initially what he said, but then in his interview he says, I have no idea how long. Like, you can't just state that in front of the jury. It's not true. So, I mean, we've always disputed the fact that he was in certain positions for certain periods of time, but to the extent that this idea of prone restraint is some like new scientific study that requires like 5 experts. I think the real issue here is that the Attorney General's office is prosecuting this case like a civil matter, right? So they have 6 experts. They want to mark over 1,000 exhibits and bring in. I was expecting almost to see an economist come up and talk about damages at a certain point. So I mean, we got to get this case moving, Judge. This comes as no surprise to the Attorney General.
We're going to take as much time as it takes,
So-
so I can tell you that much. Well, here's the deal.
Thank you, Judge.
Here's my ruling. I'm going to allow the doctor to testify, but as Ms. Eakes offered, it should only be with respect to this mechanism that we've been discussing. He can elaborate on what's been said already with respect to that. It seems to me that that his opinion with respect to the cause of death did apparently rely substantially on the condition of the heart that Dr. Wilgernettler talked about, because in his final question, I think it was, or maybe it was his penultimate question from Mr. Liu about this, that the hypoxia and the environment, being, in the prone position and so on, I assume he meant by that, did not allow his heart to function normally, which has nothing to do with his lungs, except to the extent that his lungs not functioning properly caused hypoxia, which then caused the problem with the heart. That is, for lack of a better word, Dr. W's field, and that was his initial report with respect to the electrical activity in the heart and so on, that we've, the pulseless electrical activity issue that has been tossed around here. To what extent anybody understands it, I'm not sure, but I think certainly some of the premises that the doctor had, Dr. W that is, had were messed up by that. I realized he adhered to the original conclusion, and I understand his reasons for that, and they're not unreasonable. But I don't know that we need to infect the case, if that's the right word here, with potentially misinformation about that aspect of it. So he can talk about the pulmonary part, the mechanism and so on that we had our little graphs about, or diagrams about. And how that would have an impact on somebody's ability to breathe, and how that would have an impact on somebody's ability to function. But offering the cause of death and the statistical numbers are out. All right, is that clear?
Just so I know kind of the parameters of the ruling. I mean, I intend on, if the court's going to allow him to testify, I intend on getting into the fact that he initially based his whole opinion on this PEA cardiac arrest notion, and that's now at least.
But I'm not allowing him to. I'm not allowing him to offer an opinion with respect to cause of death.
So, okay.
I think that's the last thing I said. I'm allowing him to tell us about the respiratory system and how it would impact on somebody in Mr. Ellis's condition, generally speaking, without discussing the actual ultimate cause of death here. Is that more clear?
Being that it would be hypoxia and PEA arrest.
Well, hypoxia leads to dysfunction of the brain and the heart. Dysfunction of the heart causes a heart attack. I mean, that kind of just follows, but other things could cause it too. I'm not going to allow him to offer an opinion that said, in this case, that was Mr. Ellis's cause of death. He can say Mr. Ellis was hypoxic. He can say, here's the reason why. Then he can talk about the weight on his back and his position and the circumstances of his health as all having aspects of the problem that Mr. Ellis was facing.
I guess my problem with the court's ruling is that the court's going to allow it in. I mean, his opinion, the summary of his opinion is, in my opinion, on a more probable than not basis, Manuel Ellis died due to asphyxia with resulting hypoxia and acidosis related to his strenuous exertion leading to his PEA cardiac arrest. I mean, that's one of the biggest pieces I have on this expert is that the PEA cardiac arrest is not true. So, to the extent that the court's limiting my ability to go there, I would.
I suppose you can ask the question if you want to, but that's going to open the door.
Okay. Understood.
If the state doesn't ask about it, which they shouldn't, we're fine. Because it seems to me he's cumulative as to all that other stuff. And also, I think there's a real issue about whether or not the basis for his opinion has been affected by the misapprehension of Lieutenant Wilson's experiences in the field.
Well, I think I have to go into that.
It's up to you.
All right. Thanks, Judge.
All right, that's the ruling. We're at break. Let the jury know. Okay, yes, sir, please come forward to right about here. And raise your right hand to be sworn. Solemnly swear or affirm that your testimony in this cause will be the truth, the whole truth, and nothing but the truth.
Yes, sir, I do.
Thank you very much, sir. Have a seat right there. Please state your name and please spell your name.
My name is Curtis Veal. That's C. Curtis. V is in Victor. EAL.
Ms. Flo.
Thank you. Dr. Gill, what is your occupation?
I'm a physician specializing in internal medicine, pulmonary, and critical care.
Where do you work?
Swedish Medical Center, specifically in the cardiovascular ICU for the last 12 years or so.
What are your day-to-day duties in the cardiovascular ICU?
I typically am caring for a panel of 12 to 14 patients, and these patients range from the easy ones who are post-operative patients who had bypasses or heart valves or that sort of thing. But we also have the gamut of heart disease with heart failure, worsening of chronic heart failure, respiratory failure due to heart failure, and many other cardiac conditions in that ICU. And then as well, if a patient presents to the emergency department of that campus, even if they have gastrointestinal bleeding or some other cause of their illness, we receive them into the cardiovascular ICU and do not send them somewhere else.
Doctor, you mentioned that you are an internal medicine, pulmonary, and critical care specialist. I'm going to start with pulmonology. What is that?
Pulmonology is the study and understanding of the function of the respiratory system, how we breathe.
And how long have you practiced in this area?
I completed my training in this area in 1986 and have practiced in those areas since that time.
And what does it mean to be a critical care specialist?
Critical care is much like the general internist for an ICU. That is, a critical care specialist is expected to understand neurology, pulmonology, cardiology, nephrology, GI, and endocrinology, as well as toxicology and some other areas. So we often rely on help when we need it, but we pretty much are supposed to know about all organ systems of the body and how they work.
And how long have you practiced in this area?
As I say, since 1986. Yes, sir.
What is internal medicine?
Internal medicine is the same thing I just outlined, actually, top to bottom care of patients with multiple organ system issues with the assistance of consultants, but the difference is the patients in my care are considered critically ill, and that specifically means they require some sort of respiratory support or some sort of cardiovascular support. Less common, a few other things, like diabetic acidosis, for instance, where they just need meticulous attention to laboratories and such.
And how long have you practiced in this area?
Since 1986.
Doctor, are you board certified?
I'm board certified in internal medicine, pulmonary diseases, and critical care.
And what does it mean to be board certified?
It means you've completed an accredited training program and taken an examination to demonstrate that you learned some of it. And yeah. So.
How many patients do you treat who are experiencing pulmonary issues on a week-to-week basis?
Of the census that I carry that I mentioned, over half typically have some sort of respiratory issue going on.
And how many patients do you treat experiencing cardiovascular issues on a week-to-week basis?
It's It's likely the same or even more given the postoperative heart patients in that. But understand the reason these numbers don't add up to 100% is that there's a lot of overlap. So it's very common to have somebody who has respiratory failure as well as heart failure with fluid in the lungs, for instance.
Doctor, where did you obtain your medical doctor's degree?
The Medical College of Georgia,
And when did you receive your degree?
1981.
After you received your medical doctor's degree, did you perform an internship and residency?
I served my internship and residency in the University of Washington system in Seattle, Washington.
And what years?
I was an intern from 1981 to 1982 and a resident for the subsequent 2 years.
And did you perform a fellowship?
Performed a fellowship in pulmonary and critical care from 1984 to 1986 at the University of Alabama at Birmingham.
You indicated you practice at the Swedish Medical Center, is that correct?
Yes, sir, I do.
Have you held leadership positions with the hospital?
Yes, sir, I have. I've been the director of the Quality Management Committee, the chief of staff, medical director of our critical care units for the system, beginning in the late 90s, ending about a dozen years ago. And way back when I was in residency training, I was chief medical resident at the primary Swedish facility.
Have you held any faculty positions?
I have. My first faculty position was at the University of Alabama. Upon completion of my fellowship training, I served on the medical staff as a faculty member from 1986 until I returned to Seattle in 1990. And subsequently, I've had a clinical appointment with the University of Washington medical.
What years?
Well, from 1990 until, because we used to have some trainees come through our units that no longer come through and that sort of thing, they winnowed down their clinical faculty list. So I think it's been a couple, 3 years that I've not been on the clinical faculty at UW.
Have you ever served as an expert witness, doctor?
I have.
How long have you been doing that?
Since the mid-90s.
Have you ever worked on a criminal case before, doctor?
No, sir, I have not.
This is your first one?
Yes, sir.
In the cases where you worked as an expert witness, what percentage of those cases do you work on the for the defense, and what percentage do you work on the plaintiff side?
Excellent question. As you point out, this is an unusual case for me. I typically am representing 85% maybe of my expert work entails supporting hospitals and medical providers who are being sued, and 15+% is representing people who've been injured by our system and advocating for them.
When you work as an expert, are you compensated for your time?
I am.
And are you being compensated in this case?
I am.
And what is your hourly rate when you work as an expert witness?
The hourly rate is $550 an hour.
Does the fact that you get paid as an expert witness affect your opinions at all?
Absolutely not.
Doctor, what were you asked to do in this case?
I was asked to focus on the events of this case and try to understand how this gentleman died.
What materials did you review to render your opinions in this case?
I reviewed interviews performed at multiple levels, Tacoma Police Department, Sheriff's Department, State Patrol, and AG's office of multiple police officers as well as multiple fire department members, and some others, including, I think, a sheriff's representative, or I'm not sure about that. Also, Mr. Ellis's background medical history, as well as all the, in addition to those testimonies, doorbell camera, audio and video, and bystander videos. And I'm probably not being inclusive because remember the paragraph of things I listed was like that, but that's in general what I reviewed.
Doctor, I'm going to turn your attention to the mechanics of breathing. Can you give us a basic overview of the respiratory system, and is there an exhibit that would be able to help you explain that?
Sure.
All right. I'm going to have you take a look at Exhibit 564, please. And actually, this will show up on your screen only.
Oh,
And,
okay. Excuse me. Exhibit 564 is on my screen.
All right. And Dr. Veal, will Exhibit 564 help you explain the components of the respiratory system to the jury?
Yes, sir, it will.
Your Honor, the state moves for admission of Exhibit 564 for illustrative purposes.
Okay, 564 is admitted for illustrative purposes.
State moves to publish, Your Honor.
Proceed.
And if I may approach, Your Honor, I'm going to give Dr. Veal a pointer that may assist him.
Okay. Thank you, sir.
All right, Dr. Veal, why don't you tell us what we're seeing here?
I'm going to stand on this side so you guys have the best view. There's also a projection on the screen over there. Basically the respiratory system starts in the upper airways, proceeds down past the vocal cords, which are depicted right here, into the trachea, and then you have left and right main stem bronchi, which further go out to segmental bronchi, which further go out to bronchioles, which ultimately terminate in these little air sacs that in good health, they're completely filled with gas, and the walls of them are very rich in capillaries that are able to absorb oxygen and excrete carbon dioxide, which is our main product of respiration. That's like a car has carbon monoxide. When we burn our fuels, we generate carbon dioxide. So we generate negative pressure in our chest by use of our diaphragms, as well as our intercostal and other accessory muscles that are between the ribs that we'll talk about in a bit. So we generate negative pressure, and that helps us inhale, and then when we release that negative pressure or force an exhalation, like pushing the diaphragms up, we exhale. When that gas, that oxygen-rich gas, comes into our alveoli, these little capillary beds, this blood is depicted as blue, coming from the right side of your heart. I think Dr. W. showed you some of that. It goes through this dense capillary bed and comes back out as oxygenated blood on this side, at which point it returns to the left side of the heart, which is the main pumping chamber, which pumps it out to the rest of the body.
Doctor, I'm going to next have you explain the mechanics of breathing. Is there an illustration that will assist you in explaining that to the jury?
Yes.
All right. I'm going to have you go ahead and look back at your own screen here, and I'm going to show you Exhibit 565.
I see it.
And Doctor, do you recognize that exhibit?
Yes, sir, I do.
And will that exhibit help you demonstrate or illustrate the mechanics of breathing for the jury?
Yes, sir, I think so.
Your Honor, state moves for admission of 565 for illustrative purposes.
Okay, 565 is admitted for illustrative purposes only.
The state moves to publish.
Proceed.
All right, Dr. Beal, can you explain what we're
Sure.
seeing here?
I mentioned that all those soft tissue pieces that were shown on that last diagram are encased within your thorax, which is your chest wall, ribs, and the posterior part of it is your spine. When we inhale by pulling our diaphragm down, we also, importantly, need to have our ribs able to come up. They literally pivot while we're taking a deep breath. You know, on this Halloween day, many of us can envision a skeleton. We've all seen them. It looks like they have horizontal ribs, but really our ribs are more kind of diagonal like this. And when we take a deep breath, they elevate and make your chest bigger, which is why, you know, if I laid on the floor and exhaled and then took a deep breath, you'd see my chest rise because I'm expanding it to pull that gas in there. Likewise, when we exhale, our diaphragm moves up, either passively or if I'm trying to force an expiration. And at the same time, our rib cage shrinks and the ribs move down, so they literally hinge back here in the back and move up and down with each breath, and that augments the function of the diaphragm.
Doctor, you explained sort of the movement of the ribs. Is there an illustration that could further explain the movement to the jury?
Sure.
Can I have you take a look at Exhibit 566, please?
Yes.
And Doctor, do you recognize that exhibit?
Yes, I do.
And will that exhibit help you illustrate the movement of the ribs to the jury?
Yes, sir, it will.
State moves to omission of 566 for illustrative purposes.
No objection. No objection, Your Honor.
566 is admitted for illustrative purposes.
State moves to publish.
Proceed.
And Dr. Beal, what are we seeing here?
As was depicted in the previous slide, when we breathe in, there's sort of a pump handle mechanism whereby the ribs go from being at an angle like this to more horizontal, which expands the chest and helps draw gas in. And when we breathe out, the ribs go back down. Likewise, and that's called the pump handle effect. That's just how we simple-minded doctors think of that. Likewise, bucket handle movement occurs on the lateral chest. The same joints in the back that are bringing the ribs up in the front are bringing them out on the sides. Your chest gets a little wider when you take a deep breath. And you can't have this bucket handle action unless you can have this pump handle action, meaning the sternum and the ribs have to come up in order for those ribs to flare on the lateral sides. So all of this is important in the mechanism of our ventilation, that is getting air in and out of our lungs.
Doctor, are you familiar with the term prone positioning?
Yes, sir.
And what does it mean?
It means lying on one's stomach face down.
Can prone positioning affect someone's breathing?
Prone positioning alone would impact someone's breathing a little bit. Now, many of us sleep on our stomach, so it's obviously not a life-threatening thing, but for people with large abdomens particularly, laying in a prone position presses your abdomen up. And could we go back one?
Certainly.
That's already been accepted. So when you're laying down, your diaphragm is kind of pushing against your abdominal contents if you're laying on the floor and your belly is pressing on the flat surface.
Would the effects of, would those effects on breathing be impacted by adding weight to someone's back when they're in the prone position?
Yes, sir.
And do you have an illustration that would assist you in explaining this to the jury?
Sure.
And I'll have you take a look at the screen here, and if I could have 567 shown to the witness, please. Doctor, does that exhibit look familiar?
567, it does look familiar, yes.
And will that illustration or exhibit help you illustrate the prone positioning for the jury?
Yes, sir.
State moves for omission of 567 for illustrative purposes.
No objection, yes.
567 is admitted for illustrative purposes.
State moves to publish.
Proceed.
All right, doctor, what are we looking at here?
So what we're looking at is an individual who's in prone position. And you see, in order for those ribs to go out with that pump handle movement, you've got to be able to lift your body weight up. The diaphragm is more difficult to contract because your abdomen is compressed from, your abdominal contents pushing up on your diaphragm. And then if you add weight on the back, that obviously would inhibit the ability of the person to lift their body weight and to fully expand their lungs. So that is what this is meant to depict.
Doctor, based on your review of the materials in this case, how does this discussion of prone positioning relate to Mr. Ellis' circumstances?
Based on my review, I was looking to try to understand how a person in these circumstances could develop hypoxia.
And what did you see review in the materials in this case that led you to your conclusions?
Well, I could not.
Well, let me ask you a different question. How did Mr. Ellis' prone position, can you describe, I'm trying to,
You're looking enough for me to save you because it's almost noon.
yes, sir.
Is your question is, what elements were present in Mr. Ellis's case which could have caused him to develop hypoxia? Is that where you're going?
Yes, Your Honor. I'm trying to avoid, yes.
Thank you, Your Honor.
Dr. Villar.
I heard the question. I heard permission. In Mr. Ellis's case, he had performed some pretty vigorous physical activity. He had methamphetamine in his system, as we know, which is a stimulant increasing your heart rate, your blood pressure, your metabolic rate. And he also had taser application. And those things all together would be predicted to increase his oxygen demands. And in that setting, I noted in the review that when he first had a pulse check, it had been 80 beats per minute. When he was being returned to recovery position just before E10, the fire truck, arrived. And when paramedic Wilson examined him, he described him as being bradycardic, which is less than a heart rate of 60 beats per minute. Both of those, I think we recognize, are inappropriately low. Officer Rankine said he was surprised at that pulse of 80, and the pulse of 60 was further lower, and then we saw progressive bradycardia over the ensuing minutes on the telemetry tracings.
Did you also consider, Doctor, the position of officers on Mr. Ellis?
Yes, sir. Again, the videos, as we've seen those? Okay. The videos, as you know, are difficult sometimes to see things. Officer Rankine gives a very nice description of what he saw and did. He describes that after, well, first of all, the first contact was about 21 after the hour. At 24 after the hour, officers Rankine and Ford arrive, and Officer Rankine immediately offers to assist because he is not yet, Mr. Ellis is not yet restrained fully. And so he assists in that effort while describing that Officer Burbank is sitting on Mr. Ellis's back. And at some point, by reading his description, it sounds soon thereafter, he exchanges position with Officer Burbank and describes placing his knees at kind of the base of the neck and the middle of the back, which would provide the compression. He describes at that time applying his full body weight, recognizing that if you had your toes on the ground, that couldn't be quite your full weight, but it'd be a fair amount. And I think those things together would help me explain how I might see findings of hypoxia.
How so? How did,
Well, now we are at appropriate point to break since we're down 5 minutes past. So I think a recess this time, please not discuss the case among yourselves with anyone else, and do not permit anyone to discuss case with you in your presence. And of course,